Welcome to our HTI-1 Proposed Rule Information Blocking Enhancements. My name is Lauren Reyes with Kaufman and Associates, and I will be assisting with the logistical support for this Zoom session. You can ask questions by clicking the Q&A button, which is located at the bottom of part of your screen. Click on the Q&A bottom icon, and this will pull up the Q&A box, which will open to the right side of your Zoom. You may also use the raise hand function under reaction, and we will unmute your line to verbally ask questions during the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, click the chat bubble icon at the bottom of your screen, and this will pull up the chat box to the right side. Please type the issue in the chat box, and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Mike Lupinski.
All right, good afternoon to everyone. Also good morning to those still on the West Coast, I should say, still morning there. So today is another one in our sessions on the HTI-1 proposed rule. Today, we're going to focus, as you can see on the screen, on information blocking. We're going to spend a much longer time on it than we have in many of our other presentations because the proposals in this rule build on the final policies that were in the Cures Act final rule. So we're going to try to take a step back today, talk a little bit about context here for these proposals and help inform your understanding of the proposals, hopefully. At the end, we'll talk a little bit about how to comment, what other resources we have available as well. So I'm going to be joined today with my colleagues, Rachel Nelson and Cassie Weaver. I'm just going to do the opening, talk to you about at the end, then about, as I said, the opportunities to comment. Rachel's going to run through kind of level setting, context setting for you for these proposals. And then Cassie's going to run us through all the proposals today. So why don't we move to the next slide? I'm going to go over quickly some of the disclaimers here. I'm not going to read them off the screen for you. We will be making the slides available like we always do on our website. They have to go through a process to make sure they're 508 compliant, but then they'll be available on our website for download. So generally speaking, we're going to do our best today to present the proposals in the rule as accurately as possible. However, we are human. We may make a mistake or misspeak. And therefore, we're letting you know the official proposals, rationale for those proposals can be found in the rule published in the Federal Register. We can only do so much today in terms of talking about the rule. We can't clarify something that we didn't clarify in the rule itself or provide additional rationale besides what's in the rule. And we're going to encourage you and show you how at the end to make comments on the rule. And then you also see here, there's a bullet on here that's required by law for us to note that all educational materials are produced, obviously, at taxpayer expense. So let's move to the next slide. So before I turn it over to my colleague, Rachel, I just want to try to give you a big picture and continue on with what I was saying earlier, which is that these proposals in this rule build on the policies that were finalized regarding information blocking in the Cures Act final rule. That's been almost over now, 3 years ago. And actually the applicability date was over 2 years ago, April 1st or April 5th, 2001. So the proposal in this rule really only hits on two elements of information blocking. So the first element is whether or not you're an actor, and it's actually only going to focus on one of those definitions. And then the proposals focus on the exceptions, and only two of those exceptions we're focusing on today and in the proposals. And the team will go over those in detail, the proposals, as well as some procedural proposals, I would call, related to both the definitions and with the exceptions. And so with that, I'm going to turn it over to Rachel to start by talking about some of the context, reminding you of the elements of information blocking and so forth. So Rachel, take it away. I think you're still on mute there, Rachel, just to let you know.
Okay, I went to turn the camera on. Apparently I muted myself a second time. So thank you. I will start in a sort of taking a breath and reminding ourselves of the context that the proposals are folding into. I think the first place to start is going to look familiar to a number of folks if you've seen our information blocking webinars before. Next slide, please. The overview of information blocking elements. And so what makes an individual or entity an information blocker? They have to be an actor regulated by the information blocking provision. The information involved has to be electronic health information. There has to be a practice, which, as defined in regulations, is an act or omission that is likely to interfere with access, exchange, or use of the HI. The actor has to be engaging in this practice, likely to interfere with a particular knowledge, and what knowledge is required for their practice to be information blocking is going to vary depending on whether they are a healthcare provider or they are instead a health IT developer of certified health IT or a health information network or health information exchange, as all of those types of actors are defined in 45 CFR Part 171, Section 102. The practice, in order for it to be information blocking, also has to not be required by law. And law in this instance, as we said in the 2020 final rule, could be federal, state, or tribal, where tribal law is enforced. And a law or legal requirement could be in a statute or it could be in a regulation. And finally, in order to be information blocking, one of those practices likely to interfere with access, exchange, or use of VHI has to not be covered by one of the exceptions. Next slide, please. And this is just a review and a reminder. I mentioned that there are two different knowledge standards, and here is what they are. For healthcare providers, they have to know that such practice is unreasonable and is likely to interfere. And for health IT developers of certified health IT or HINs or HIEs, the standard is that they know or should know that the practice is likely to interfere. Next slide, please. And a refresher and a review of the definition of information blocking, electronic health information for information blocking. At this point in time, we are beyond that startup period where we focused the information blocking definition down a little bit on a subset of EHI, and we are looking at the full definition of EHI. You can find this definition in regulation right now in section 171-102. EHI means electronic protected health information, EPHI, to the extent that the EPHI would be included in a designated record set as these terms, EPHI and designated record set, are defined for the HIPAA rules. Except for, EHI does not include psychotherapy notes as defined in the HIPAA rules at section 45 of 45 CFR 164-501. And EHI also does not include information compiled in reasonable anticipation of or specifically for use in a criminal, civil, or administrative action or proceeding. The definition of EHI for information blocking purposes is applicable whether or not the information is held by or for a HIPAA-covered entity. Next slide, please. And now a little review. Again, the definition of information blocking. I'm not going to take a lot of time looking at this because we stepped through it on the elements slide. I just wanted to point out that this familiar slide from our information blocking introductory sessions, as we're showing it today, shows a strike through in paragraph B, which is where we established that narrowing down the focus on the subset of EHI that was represented by an element within USCDI version 1. One of the proposals that Cassie will talk about in a little while is to update the text of the information blocking definition to remove that paragraph now that the time when that focus limitation is over. So we're past the time and we're proposing that that paragraph go away. Next slide, please. And this is a big picture reminder that there are 8 existing exceptions. And here's what they are, just in the short list. 2 of them are bolded on the screen right now. Those are the ones for which there are proposals in the HTI-1 proposed rule that Cassie will talk more about in a few minutes. Next slide, please. It's hard to give context about information blocking without getting at least one question or raising a question, at least, about information blocking enforcement. And we'll do a little quick review and quick update, which may also be review for some folks on the line. Next slide, please. And this is just a review of the familiar table to many folks. What are the consequences for information blocking? Well, it depends what type of actor you are. Healthcare providers, the consequence per the statute is appropriate disincentives. These are appropriate disincentives to be established by future HHS rulemaking. Health information networks and health information exchanges, as well as health IT developers of certified health IT, the statute authorizes civil monetary penalties up to $1 million per violation when these actors have been determined by the HHS Office of the Inspector General to have committed information blocking. The civil monetary penalties enforcement dates will be established by an OIG rulemaking that I'll talk a little bit more about coming up on the very next slide. Next slide, please. The OIG information blocking rule. It was proposed in 2020. And you can see on the screen, there is a Federal Register citation for anyone who missed it or just wants to go back and reread it. The final rule is currently making its way towards publication, and we hope to see that that goes public and is viewable by everyone in the next few weeks. And next slide, please. And provider disincentives. We mentioned a lot that the statute says healthcare providers who are determined by the Office of the Inspector General to have committed information blocking should be referred to an appropriate agency for application of appropriate disincentives. There is a disincentives rulemaking on the currently published unified agenda of regulatory actions. And the target publication date, as you can see on the screen, is sometime in September of this year. So we do not have the proposed rule for provider disincentives on the street yet. We have a plan posted on the unified agenda. And there's the abstract, which is as much as we're prepared to publicly say about what's in that rule. at this point in time. In the meanwhile, next slide, please. But we have stood up what the statute requires ONC to maintain, which is a standardized way for people to share with us any claims or suggestions of possible information blocking that they would want us to know about. This slide, which is also in a little different format, although mostly I think it's scaling of the image, is available as a fact sheet on our website on the information blocking topic page, healthit.gov. And it walks through what happens when we get a claim. We acknowledge receipt. The system actually does that automatically unless we're having a technical issue. And then we triage, does it appear to be a claim against a healthcare provider? If it is, then that would be in scope for OIG authority under the statute. If it is not a claim against a healthcare provider, is it a claim against a health information network or health information exchange? If yes, OIG authority, OIG may investigate. Is it a claim against an offerer of certified health IT? If yes, then the OIG may investigate and may issue civil monetary penalties, as they could for the HIN or HIE. If not any of those three things, if it is the claim is against a health IT developer, a certified health IT that actually participates in the program. So they meet the definition of health IT developer, certified health IT, not by offering certified health IT developed by someone else, but by actually developing it and presenting it for certification that under the program themselves, then yes, it is, they are subject to OIG authority. OIG may choose to investigate and may issue civil monetary penalties. Again, the dates when OIG activity might begin in this area, please stay tuned for that final rule. Where it is a health IT developer who participates directly in the ONC Health IT certification program, ONC may also, under our separate authority, review the situation, and we may take action such as requiring that the developer implement a corrective action plan under the ONC Health IT certification program, where there is, as a condition as certification, a requirement that program participating developers not engage in conduct that constitutes information blocking. If you don't have any of the information blocking actors, it could be any one of a variety of kinds of individual or entity who have other kinds of health IT. For whatever reason, they just do not meet the definition of any kind of actor. It's not an information blocking claim. So in the triage process, it probably would not be referred over to OIG, it would be held on record. Next slide, please. We've been gathering claims for the last 3 years. You know, from those slides we've just reviewed, we don't have any completed investigations yet. We do, at this time, make some information available. It is updated monthly on how many claims we have received since the applicability date of the information blocking regulations, which was April 5th, 2021. And this monthly update will show how many claims did we get, how many submissions did we get that by triage don't appear to be an information blocking claim, but something else somebody was trying to tell us. And it will show basically how many of the claims appear to be suggesting possible information blocking by each type of actor. We have a blog, you'll see there on this slide, that explains a little bit more about what the numbers show and don't show. And one thing we said in the blog that we put up when we did our first release of the numbers in April of 2022 is even though not every claim will necessarily be investigated, every claim is helpful. It joins the collection of claims that together are a source of information for us about what barriers and challenges and frustrations people are experiencing as they try to access, exchange, and use electronic health information out in the environment. And anyone can go and look at what the quick stat says about our claims counts to date. Also, anyone who thinks they have seen something that is, in their opinion, or they think might be, could be, information blocking is very, very welcome to report that claim or suggestion of possible information blocking through our information blocking portal. We can put that link up in a number of different places during this webinar today, but you can easily find the button to report information blocking on the healthit.gov/feedback page. And with that reset and context setting for the proposals, I am going to turn over to my colleague Cassie to talk about what we are proposing in HTI-1 proposed rule.
Thanks so much, Rachel. Can we go to the next slide, please? So that background is going to be really helpful because as we walk through these proposed enhancements to the IB regulations, we're going to want to keep in mind not just what they are, but why we're proposing some of these enhancements or changes. So I appreciate that, Rachel, and I think our audience does as well. Let's go ahead to the next slide, please. So today we're going to cover all of the information blocking related proposals in HTI-1. And to keep us organized, we've sorted them into a few different categories. First, we are adding and updating a few definitions. We're also proposing 3 new conditions for the exceptions. 2 of those new conditions are in the infeasibility exception, and 1 is in the proposed newly renamed manner exception. And finally, we also have 3 requests for information, or RFIs, in this proposed rule that are in some cases mostly related also to these enhancements that we're proposing. So taking these in order, next slide, please. We'll start with the proposed updated definitions. Next slide. We are proposing to update the definition of information blocking, which sounds like a major change, but actually isn't, because currently the definition of information blocking at 171-103 looks just like this, except that it includes a paragraph that says for the period before October 6, 2022, EHI for purposes of this section is limited to the electronic health information identified by the data elements in the USCDI standard. In a later rule, we changed that applicability date to April 5th, 2021 in light of the public health emergency caused by the COVID-19 pandemic. And since we are now a couple of years past that date, we're taking the opportunity in this proposed rule to remove that paragraph referring to the date. And by removing that, we're also relettering it so that what is now paragraph B used to be the numbered paragraphs under paragraph A. So that's it for this one. Everything else here is the same. Next slide, please. The other definition that we're proposing to do some work on is health IT developer of certified health IT. This is the current definition, and I want to draw your attention to the part of this that says a health IT developer of certified health IT means an individual or entity other than a healthcare provider that self-develops health IT for its own use, that develops or offers health information technology. So a couple things here. First, we've received a lot of questions about what exactly it means to offer health IT. So we're proposing a definition for that. And in conjunction with that, we're proposing to clarify what exactly it means to be a healthcare provider that self-develops health IT for its own use. So next slide, please. Defining offer health IT. We're proposing to add a new definition to our definition section 171-102. Why? Because we've heard some confusion about what it means to offer it, and we think clarity will help to ensure that certain donation schemes and other things like that remain available while holding accountable the right actors for health IT implementation. This new definition will generally cover any actors providing, supplying, or otherwise making available health IT under any arrangement or terms, except for certain reasonable and necessary activities, which we propose to explicitly exclude. We want to give healthcare providers and others who are using certified health IT certainty that implementing certain health IT features and functionalities and engaging in certain practices like generating logins that are common in an EHR-enabled healthcare environment, they can be confident that those actions will not be considered offering health IT. And you might be wondering, why does it really matter since providers are also actors? It goes back to those consequences that Rachel just discussed, where developers are subject to a $1 million civil monetary penalty and face other consequences under the ONC Health IT certification program, whereas healthcare provider actors are held to a slightly lower standard of knowledge and reasonableness and are subject to those appropriate disincentives. So it's definitely important for providers to know which category they're in at any given time. Please do review the proposed reg text and the preamble. I'm going to say that a lot, but I'm summarizing here that offer health information technology or offer health IT means to hold out for sale, resale, license, or relicense, or to sell, resell, license, relicense, or otherwise provide or supply health IT, as that term is defined in 42 USC 300 JJ5. That includes one or more health IT modules certified under the ONC certification program that's for use by other individuals or entities under any arrangement other than the following. And then we go on to list out 3 fairly detailed exclusions. So we're proposing to say that an actor won't be offering health IT if it's being offered under a donation and subsidized supply arrangement, when the offer is made without conditions limiting, for example, the interoperability of the tech. We're also proposing to exclude from this category those who undertake certain implementation and use activities like issuing user accounts for their organization, making available certain API production instances, things like that. And then the third exclusion covers certain consulting and legal service arrangements. Again, the details are in the definition, so please do take a look. In parallel to this offer health IT definition proposal, we're also proposing to modify the health IT developer of certified health IT definition so that it remains clear that healthcare providers who self-develop certified health IT would continue to be excluded from this definition if they do not offer, as proposed in 171-102, their self-developed health IT to others. Next slide, please. So that's actually it for the definitions that we are proposing to update. Next, we are going to talk about some of the updates to the manner exception, which is currently called the content and manner exception. So next slide, please. So right now, the content and manner exception has 2 paragraphs, A, which is the content condition, and B, which is the manner condition. The content part of this exception currently says that an actor must respond to a request to access, exchange, or use EHI with USCDI for the period before October 6, 2022, which we discussed earlier. That date has passed. So we're proposing to remove that and leave it as an actor must respond to a request to access, exchange, or use EHI with all EHI as defined in 171-102. So since we passed that date, we're using all EHI. We're going to sort of clean up this part of the regulations. We'll eliminate that content condition entirely and keep only the manner condition and rename it appropriately to call it just the manner exception. So now this proposed new manner exception we'll start right off with this section. When will an actor's practice of limiting the manner in which it fulfills a request to access, exchange, or use electronic health information not be considered information blocking? And then we have the two conditions which are currently in place, which is first A, when an actor provides the access, exchange, or use of EHI in any manner in which it was requested, in which case the actor and requester can come to whatever terms they wish, or if the actor and requester can't come to agreement, or if the actor is technically unable to provide the access, exchange, or use in the requested manner, then the actor provides the EHI in an alternative manner as agreed to by the requester. In which case, if the actor is providing it in an alternative manner, the actor is bound by the restrictions in the fees and the licensing exceptions in the information blocking regulations. That part would remain the same, just re-lettered. So let's go to the next slide, please. And we are proposing to add a new condition to this exception, the TEFCA manner. So just walking back through, we have the manner requested, the alternative manner, and now we're proposing to add the TEFCA manner condition. So the substantive update here is adding this new condition that would allow an actor to meet this manner exception without having to meet either of those other two conditions I just discussed, the manner requested and alternative manner. And this new proposed condition is the TEFCA manner condition. TEFCA is the Trusted Exchange Framework Common Agreement, which was another requirement from the CARES Act that ONC has undertaken. And the Trusted Exchange Framework is a set of non-binding but foundational principles for health information exchange. And the Common Agreement is a contract that advances those principles. The Common Agreement establishes the technical infrastructure model and governing approach for different health information networks and their users to securely share clinical information with each other. This condition would give qualified health information networks, QHINs, participants, and sub-participants in TEFCA the ability to fulfill EHI requests from any of those same actors or members of TEFCA, QHINs, participants, and sub-participants, using TEFCA means, even if the requester would have preferred other means. So the TEFCA manner condition is this additional option under the revised and renamed manner exception, but the manner requested and alternative manner conditions remain available to QHINs, participants, and sub-participants responding to any requesters. We're just making this available. It's not a requirement like all exceptions. It's voluntary. So the establishment of this TEFCA condition would not preclude a QHIN, participant, or sub-participant actor from making a different choice with respect to supporting non-TEFCA means and complement to TEFCA means of information sharing with others who choose to become QHINs, participants, or sub-participants. And on this slide here, you see some of the benefits of this condition. Obviously, it promotes interoperability, acknowledges that certain agreements have already been reached for the access, exchange, and use of EHI under the Common Agreement. So it's creating efficiency for those actors who participate in TEFCA to go ahead and use those TEFCA means that they've already agreed to, and facilitates those agreements on agreeable terms with the requester. Next slide, please. Here is the proposed regulatory text for this TEFCA manner condition, which says that if an actor who is a QHIN, participant, or sub-participant offers to fulfill a request for electronic health information access, exchange, or use for any purpose permitted under the Common Agreement and Framework Agreement from any other of the same, using connectivity services, QHIN services, or specified technical services from the applicable framework agreement that is available to both parties, then the actor doesn't have to offer the EHI in any alternative manner, and any fees charged by the actor don't have to satisfy the restrictions found in the fees and licensing exception in the information blocking regulations. So you can see that it parallels those same sort of incentives in the manner requested condition. in that you don't have to satisfy those fees and licensing restrictions in those exceptions. Just to note here, this doesn't allow an actor to charge any fees that another law or contractual agreement have already prohibited. It also doesn't allow an actor to offer EHI that it's prohibited from offering by the common agreement or other law. This only covers the practice. It doesn't, like all of these exceptions, it's voluntary and doesn't give actors permissions to break other laws or contracts or regulations that could also govern the exchange. Next slide, please. So as you probably noticed, reading that proposed condition, there are quite a few new terms that haven't been used in the information blocking regulations previously. So we're proposing to add them here to this condition only. I won't read these all out to you, but we're proposing to define QHIN, participant, sub-participant, connectivity services, framework agreement, and QHIN services. And these terms all come from TEFCA, and we're working closely with our TEFCA partners within ONC and with our RCE to make sure we're getting this right. Next slide, please. Okay, so we've covered the proposed new definitions and the proposed updates to the content and manner exception. Arguably here, we have the infeasibility exception, which is maybe one of the more complex ones. So this is going to take a little bit more time to step through all of these. We're proposing to clarify one of the current conditions and then add 2 new entire conditions to this exception. Next slide, please. Okay, so I'm going to use this slide to set the stage a little bit, so bear with me. Right now, in current regulations, the infeasibility exception has 1 required element, which is paragraph B that you see at the bottom, and then 3 conditions that an actor could meet any one of in order to satisfy the exception. The required element, paragraph B here, is staying the same. That paragraph says that if an actor does not fulfill a request for access, exchange, or use of electronic health information for any of the reasons provided in paragraph A of this section, so for any of the infeasibility conditions, then the actor must, within 10 business days of receipt of the request, provide to the requester in writing the reasons why the request is infeasible. So that's still required. Again, today, the first condition, A1 of the infeasibility exception, is the uncontrollable events condition, which we're proposing to clarify really as a revision. And then, sorry, I made the mistake of looking at the questions. So we're proposing to clarify uncontrollable events. The second, A2, is the segmentation condition, which we're leaving the same. And then today, in the current regulations, the third condition is the infeasible under the circumstances condition, which we're proposing to move to A5 to make space at A3 and A4 for the 2 new proposed conditions. And before we look at those new conditions, I want to review this infeasible under the circumstances condition because it will be important later. So again, as it stands today, in order to ensure an actor's practice of not fulfilling a request to access, exchange, or use electronic health information because it is infeasible under the circumstances, an actor has to demonstrate through a contemporaneous written record or other documentation its consistent and non-discriminatory consideration of 6 different factors, which I'm going to summarize, but summarized here as the type of EHI, the purpose for which it's needed, the cost to the actor of complying with the request in the manner requested, the financial and technical resources available to the actor, whether the actor, whether the practice is non-discriminatory, and if the actor provides such access to its companies or customers, whether the actor owns or has control over a predominant technology or platform through which electronic health information is accessed or exchanged, and why the actor was unable to provide access, exchange, or use consistent with the alternative manners listed in the content and manner exception. We stated in the Cures Act final rule that we included these factors because we wanted infeasibility to be an exception of sort of last resort and to encourage actors to supply the EHI if at all possible. Okay, next slide, please. So the first proposed change to the infeasibility exception is to revise that first condition, the uncontrollable events condition. We're proposing to adjust the language in this condition so that it's more clear that the infeasibility is because of the uncontrollable events. Currently, the condition says that providing the EHI is infeasible due to an uncontrollable event. And we just want to make sure that it's clear that there has to be a causal event between, or a causal connection, sorry, between the event and the infeasibility. Just the fact that an earthquake occurred or that there's a public health emergency isn't enough. There has to be causality. And we explain that in the preamble to the Cures Act final rule. So this isn't a substantive change. It's just a proposed language change so that we make sure that it's really clear. Next slide, please. Okay, this is one of two new conditions. So this is an entirely new condition in the infeasibility exception that an actor can meet along with the requirements in paragraph B of the infeasibility exception in order to have a practice that could be considered an interference, not be considered information blocking. So we propose that an actor may consider certain requests infeasible without going through those 6 factors I listed a few minutes ago, or without satisfying the slightly more onerous requirements of the security or health IT or privacy exceptions, when the request is from a third party to modify EHI, including, but not limited to, through creation and deletion functionality, unless the third party request is from a healthcare provider requesting such a use from an actor that is its business associate. So I want to note, emphasize, and repeat as many times as I can that just because an actor can't satisfy this condition of the infeasibility exception, all of the other conditions are available and all of the other exceptions are available as well. So if there's an actor who wants to undertake a practice with their own business associate and are therefore excluded from this condition, they can still look to other exceptions to see if their practice might be covered as a reasonable and necessary activity elsewhere. We also want to note that nothing in the information blocking regulations requires an actor to permit any access, exchange, or use of EHI when such access, exchange, or use is prohibited by law. We get questions about what may or may not be in a given business associate agreement. It's not relevant to this condition, however, because it just doesn't apply if there is a business associate involved, but business associate agreements are relevant, and I would refer you to our FAQs in that there can be conditions inside or contractual requirements inside of a business associate agreement that could constitute information blocking. That is separate from this condition and exception. So next slide, please. So when is this condition available? It's available where an actor is asked to provide the ability for a third party or its technology, like an app, to modify EHI that is maintained by or for an entity that has deployed certified health IT and maintains within or through that technology any EHI. It's not available when the request is from a healthcare provider who's requesting the EHI either directly or through one of its own business associates, such modification use from an actor that is its business associate. I know this sounds confusing because of the double negative, but I think looking at the policy behind it helps. So, for example, an actor may be concerned about the accuracy or the reliability of data that a third party would like to add to an individual's designated record set that's maintained by that actor, rather than spending resources determining if the preventing harm or security exception apply, or to consider all of the factors required to determine that a request may be infeasible under the circumstances. An actor may be able to make use of this modification use condition if it's finalized as proposed. More specifically, for this example, an actor might be unable to complete a third party's request to modify or add EHI in the specific way that it was requested. Rather than working through all of the alternative manners, the actor could use this third party seeking modification use condition without needing to engage in information gathering or analysis that would often be needed to work through those available alternative manners. So the question then is, why limit it such that business associates of a healthcare provider can't use this exception against the healthcare provider? And so we propose to exclude from applicability of this condition requests from healthcare providers to their business associates, where those business associates are actors, such as developers or HINs or HIEs, because the exceptions to the information blocking definition are intended to only cover reasonable and necessary practices of interference that would otherwise constitute information blocking. Covered entities, healthcare providers, and their business associates, as permitted by their business associate agreement, need to access and modify relevant EHI held by other business associates of those covered entities on a regular basis. So ensuring this condition does not apply to practices of one business associate actor that are likely to interfere with healthcare providers and their other business associates' ability to access, exchange, and use EHI maintained by or for the healthcare provider, promotes greater interoperability, efficient transitions of care, and protects the use of EHI as needed to maintain operations. Also, there's often a level of trust and contractual protections between covered entities and business associates that removes some of the other concerns, like the security and data provenance, that led us to propose this new condition in the first place. Further, many concerns were expressed by healthcare providers and their business associates to ONC in the development of the information blocking report to Congress and the ONC Cures Act proposed rule. There were concerns that certain business associates that were also actors under the information blocking regulations were committing interferences with access, exchange, and use of EHI. So we don't want this covered because this was a specific concern that had been communicated to us and then to Congress as a practice of interference. So it would not constitute a reasonable and necessary activity. I again emphasize that other federal and state laws may apply, and other information blocking exceptions or conditions of the infeasibility exception are available and may apply to those relationships and requests for EHI access, exchange, and use. It's just not, this condition just would not be available if adopted as proposed. As a side note here, we do also propose to add the definition of business associate to the definition sections of the information blocking regulation at 171-102 and use the same definition of business associate that's in the HIPAA regulations at 45 CFR 160-103. The preamble here for this proposed rule has lots of examples when this condition would and would not apply. So I really encourage folks who are still confused to read that portion and see if maybe that doesn't clear up any of the confusion, because I think it probably will really help folks to understand better in case those examples I just gave don't. Next slide, please. Okay, so separate entirely from infeasible under the circumstances and the other conditions is this manner exception exhausted condition. Again, this proposed condition could be satisfied independent of all of the other conditions in paragraph A of the infeasibility exception, as long as all of the requirements of paragraph B are also satisfied and any of the requirements within this condition. Excuse me. Okay, so the proposed manner exception exhausted condition would apply where an actor is unable to fulfill a request for access, exchange, or use of EHI despite having exhausted the content and manner exception in 171-301, which we are proposing to rename as the manner exception, including when the actor has offered all the alternative manners in accordance with 171-301B, the alternative manners that we discussed before, so long as the actor does not currently provide a substantial number of individuals or entities similarly situated to the requester the same requested access, exchange, or use of the requested EHI. So just kind of taking that in order. First, what does it mean to exhaust the content and manner exception? First of all, it means that the actor and requester either couldn't reach agreeable terms on fulfilling the request in any manner requested, or that the actor, or it was technically infeasible for the actor to provide access, exchange, and use in any manner requested. Again, when the actor does provide in the manner requested, they're not restricted by fees and licensing, can come to any agreement with the requester. If they move to the alternative manner, then those restrictions and fees and licensing do apply, and the actor must fulfill the request in an alternative manner agreed upon with the requester. And those alternative manners prioritize interoperable manners based on HHS adopted and available open source standards, certified health IT software. So why propose to add this? For one thing, actors have expressed concerns that a requester could simply refuse to accept any of the alternative manners. And fulfilling the request would require substantial technical or financial resources, or would result in an outcome that doesn't further interoperability and is sort of a unique one-off build. And so for actors who have significant financial or technical resources, this uncertainty could result in their investing in non-standard, non-scalable solutions that they don't support even after they've offered to provide it in the same manners that they generally make available to their own customers or affiliates, and through alternative open source standards. So this proposed new condition would help to reasonably allocate resources to ensure that they are going to more interoperable means than less. So in order to satisfy this new proposed condition, an actor would be considered unable to fulfill a request for access, exchange, and use of EHI when three factors are true. So first, the actor could not reach agreement with the requester in accordance with 171-301A manner requested, as we've proposed to name it in the new rule, or was technically unable to fulfill a request for electronic health information in the manner requested. Second, the actor offered all alternative manners in accordance with 171-301B alternative manner condition for the electronic health information requested, but could not reach agreement with the requester. And the third factor is that the actor does not provide the same access, exchange, or use of the requested electronic health information to a substantial number of individuals or entities that are similarly situated to the requester. So the first and second factor I already discussed, those are the ones that require the actor to try to work through the content and manner exception first. The third proposed factor allows a reasonable limit on the use of this condition without having to take into consideration the financial and technical resources available to the actor. And we're trying to exclude those for the reasons I just discussed, that those actors in particular are in a place where any uncertainty could lead to them doing unreasonable activities such as building one-offs. So this factor as a whole serves sort of a similar function to the infeasible under the circumstances conditions factor, considering whether the actor's practice is non-discriminatory, whether the actor provides the same access, exchange, or use to its companies or to its customers. It provides a basic assurance that actors would not be able to misuse the manner exception exhausted condition to avoid supplying some particular requesters with manners of access, exchange, or use of the requested EHI that would be more accurately characterized as generally available rather than as new, unique, or unusual. And we chose to structure the factor in this way to align with that concept of whether the manner requested, including any involved interoperability elements, is in a stage of development or overall life cycle that would roughly approximate the general availability phase of the software release lifecycle, or something analogous for non-software interoperability elements. And by same access, so the actor does not provide the same access, that means the same manner. And then to a substantial number. So what might be a trivial number to a large health IT developer of certified health IT might be an important or consequential, substantial number for a small HIN or HIE. We propose in the alternative, so we propose this, but then we also propose in the alternative that we would, and seek comment on whether we should, instead construct this factor with a simple fixed threshold, say of more than 1, or more than another specific number between 1 and 10. Such a fixed threshold would offer more simplicity to actors and potential requesters, while still assuring that an actor's practice would not fail to meet this factor on the basis of a single instance of a particular access, exchange, or use manner. And then the last thing I want to talk about here is that similarly situated part. So this should be familiar to information blocking actors. We also used similarly situated in the fees and licensing exceptions at 171, 302, and 303. It would serve here as it does there to indicate that different specific individuals or entities within a class of such individuals or entities who are similarly situated to one another should be treated in a consistent and non-discriminatory manner. So again, by using similarly situated, we're ensuring that some of those factors from the infeasible under the circumstances are brought in to this new proposed manner exception exhausted condition. I want to give an illustration from the preamble that I think might help sort of explain why we are proposing this condition. So to illustrate the situation, we see and believe this new condition is necessary to remediate. An actor that develops or offers certified health IT may, for example, be uncertain as to whether an information blocking exception covers its practice of denying a requester's demand for access, exchange, or use in a particular manner that relies on unique specifications instead of interoperable standards. For example, standards identified in the alternative manner, because the actor has capabilities and resources that it could potentially divert to the requester's preferred manner. In such cases, the actor may also lose the opportunity to pursue other innovative endeavors or fulfill other customer requests. Healthcare provider and HIN, HIE actors with substantial technical and other resources also face demands from requesters who are interested only in their own preferred mechanisms, however unique and non-scalable. We're concerned that actors currently appear to experience such uncertainty, even if, to continue this illustration, the actor is offering the requester interoperable manners of access, exchange, and use based on open, consensus-based industry standards. And diverting resources to build the new manner would mean the actor would need to delay for months or more deployment of innovations that will reduce burden on clinicians using the software. In these cases, we currently can't advise these actors whether or not the requester's demand is infeasible in the actor's unique circumstances. We also don't have advisory opinion authority from Congress that would allow us to provide responses to these fact-based scenarios that we often face. So I think I've covered everything on this slide. The benefits are there at the bottom. I think we talked about those, that it ensures actors can reasonably allocate their resources towards interoperable standards-based manners, reduces inappropriate, unnecessary diversion of resources, and provides that certainty that we don't think actors currently have. So that's the proposed manner exception exhausted condition, which is the second new condition proposed for the infeasibility exception, along with that revision to infeasible due to unforeseeable circumstances condition. Next slide, please. Okay, we did it. We're at the third portion of the proposals in HTI-1 that relate to information blocking, and these are our requests for information. And while we welcome comment on any aspect of the rule, requests for information are especially important to us because it is something that we are looking into and trying specifically to learn more about. A lot of or there's 3 requests for information in this rule that specifically relate. And as I was reading through, I noted a couple places where there were alternative proposals, and we also obviously request more information on those. So next slide, please. In relation to Offer Health IT, we seek comment on whether we should consider proposing in future rulemaking any additional exclusions from the Offer Health Information Technology or Offer Health IT definition that we're proposing. So are there other things besides those that we're proposing to exclude that ought to be included in this definition so that we aren't eliminating reasonable and necessary activities that are offering health IT that would currently be covered? Next slide, please. This request for information relates to TEFCA, and we are seeking comment on whether any other practices that aren't otherwise required by law, but are required by an individual or are required of an individual or entity by virtue of their status as a QHIN, participant or sub-participant under the common agreement, may pose a substantial concern or uncertainty regarding whether such practices could constitute information blocking. So like I said, we are working with the TEFCA folks closely to make sure this is all aligned and in harmony, but you know, there are always blind spots. And if folks are seeing things that we're missing, please do submit comments on that and let us know. Next slide, please. So this is our final RFI, and we are requesting information on health IT capabilities for data segmentation and user patient access. We seek comment to inform any steps we might consider taking to improve the availability and accessibility of solutions that support providers and other actors' efforts to honor patients' expressed preferences regarding their EHI. More information on all of these RFIs, which are actually much more detailed than I'm reading here, can be found in the preamble text. So if you have thoughts on them, please do refer to the preamble text so that you can see if there's anything else you can tell us about this. Next slide, please. At this point, I am going to hand it back to Mike to let you all know how to learn more and to submit your comments. Thanks, everybody, for giving me the opportunity to present this. Mike?
All right, thank you, Cassie. I know there's a lot to go through. Really appreciate you taking time, and hopefully that was helpful to all our attendees today. Generally speaking, a couple points. We can only, like I said in the beginning, explain the rule in the proposals in the way we have in the rule. We can only clarify in the same manner that we've clarified in the rule. This is a proposal, and this is a perfect time right now to talk about how you have an opportunity to ask, submit comments, ask questions for clarifying if something was not clear, or even examples of particular how a particular proposal would apply through the comment process. And that's what I'm going to talk a little bit about now, how you can participate, how you can learn more, get more involved, understand more about this rule. So why don't we jump to the next slide? We are actually today halfway through the comment period. You get a few more days because the end of the 60-day comment period ends on a weekend. The Monday is a holiday, so you're actually the end of the comment period isn't until June 20th. So it's a few more days than 60 days, but 30 days in as of today. Okay, if you want to learn more, we have fact sheets. We just released 2 fact sheets today. We released one on information blocking, and we released one on our proposals related to update and provide certified health IT under the program. We already had other fact sheets out. There's including a measure spec sheets, they're called, and those are for the insight condition measures. So if you really want to dig deep about how those measures, how it would be reported, you can take a look at those as well. As we find the need or to issue more fact sheets, we'll try to do that. Obviously, knowing that we're halfway through the comment period. Let's move to the next slide. Webinars. So As the title of this says, there are still upcoming ones, but there have been past webinars. And I can't remind you enough that if you've missed those, you can go to our website, download the slides, actually rewatch the webinar itself. So we did a overview of the whole rule. We did a webinar just on clinical decision support, or now proposed to be called DSI, decision support interventions, and the algorithm transparency proposals. We did one just on the insight condition. And now we just did one on information blocking. And next we'll be trying to discuss the rule in a way for caregivers, patients to provide more informed comments on the rule. We understand, in a Word version, it is a 500-page rule. So we're going to hope to help break that down for patients and caregivers so they can provide comments. And then, as I've been mentioning in the chat, if we don't get your Q&As today, please try to come back. We're going to have the date now is going to be June 8th. We're going to have a very brief overview of the whole rule, and then we're going to try to answer any questions about the entire rule in the time permitted. So encourage you to come back to that. I believe my colleagues are putting information in the chat on how you can register for that. So that'll be June 8th again. And then on June 1st, we will have one, just as I said, focused on trying to explain the rule for patients and caregivers and what they should be interested in or focus on when it comes to our proposals. Let's move to the next slide. So if you really, really, really want to dig in, there's another public way to do that as well besides these webinars. So we have what's called a Federal Advisory Committee, the Health IT Advisory Committee, and they are tasked with looking at all the proposals on the rule, in the rule, I should say, and they will eventually provide recommendations to us through the comment process. So each week, they've broken it down into, I think, 3 subgroups, this task force, and they're looking at proposals, and we present them. So our staff presents those proposals to them. They ask a lot of questions. At the end of each 1.5, 2 hour, I think it's 1.5 hour session, the public can actually comment. And then all that information is, again, available publicly. And then ultimately the full committee will provide us recommendations based on the work of the task force. Next slide, please. So how you can submit a comment. So you can go to the Federal Register. There's actually a spot right here on the screen. It's showing you how to do it step by step, where you can click and that'll take you to regulations.gov. And that's where you'll be able to submit your comments online. That is the way we encourage all comments to be submitted. There are other ways to submit comments, and I will just note that you can find those instructions in the Federal Register under that heading for submitting comments on the rule. But obviously encourage you to submit those comments via regulations.gov. And I want to say one more thing about comments. Cassie talked about some of the areas where we specifically requested comments. You should feel empowered to submit any comments regarding proposals in this rule, or maybe information blocking in general. While we may not be able to use those to change a final policy in the final rule, we can use those to inform future rulemaking, and I will tell you why that is quite relevant right now once we get to that slide. So we can move to the next slide, please. Oh, so one more thing on how to submit comments. We've provided a template. We also provide a Word version of the rule. So if you were looking to try to cut and paste, well, you can do that also now that the Federal Register makes rules available online. But if you wanted to do that or use our common template, that's available at healthit.gov. And it really breaks down the rule about by each section and proposal, and then gives you a cross-reference to the CFR, or excuse me, to the Federal Register where that proposal is. So we also encourage use of that. It helps organize your comments, make sure you didn't miss something, and then it helps us on the other side when we're reviewing comments in terms of making sure we've captured all your comments and fully considered them. Let's move to the next slide. So this is what I was talking about. So we have another rulemaking planned as well. So besides HTI-1, this will become, it's not called HTI-2 yet officially, because this regulatory agenda, unified agenda that you're looking at, was published on January 1st. And it's a long process leading up to actual publication. But the spring one will publish most likely June. And you'll see a new update of both the summary and the other information on here, including the title being changed to reflect the concept of our new naming convention concept of HTI. But again, to my point about submitting comments, those comments could help inform proposals in this rulemaking that is scheduled currently to be released in November of this year. Can we move to the next slide, please? Okay, so it looks like we still have a significant amount of time. So as I was mentioning, maybe with or without clarity, we will try to answer some of the questions provided in the Q&A. I did want to point out again something that you may have missed that Cassie said about what it called binding advisory opinion authority, which really allows us to apply the full scope of the information blocking regulations and information blocking definition to a set of facts and circumstances. So it would look at whether or not the alleged subject met the definition of an actor under the rule. It would look at whether they had the requisite knowledge. It would look at whether there was an actual, whatever action they took rose to level to meet the definition of an interference, which includes not just an actual interference, but if they materially discourage access, exchange, or use. And also would look at whether there were any laws that required the information not to be released. And then lastly, obviously, whether any exception applied in the circumstance. So that that binding advisory opinion authority is in the current request is in the current administration's budget request for fiscal year 2024. So we'll see, what Congress ends up doing with that. But now I think we could probably turn to questions. And I know there was a few I was looking at, and I'm happy to start. I guess perfect would be to start with the first ones that came in from Debbie Willis, asking whether the two examples she provided would be information blocking. This kind of goes to whether or not we, how much guidance can we provide, and in terms of, we could talk about, and what we have done on our frequently asked questions, which I think are up to 50, and the 51st one should be issued anytime in the near couple next days. But there we talk about various elements, and what we can talk about is like, would something be would or would likely not be an interference. So we can talk about one element of the information blocking in terms of our guidance, but we really can't put together whether or not, without a very specific set of facts and circumstance, whether that actor was an actor, that alleged subject was an actor, that they had the requisite intent. This is an intent-based statute, which is the key piece, and then whether any exceptions applied in that circumstance. But one of the questions there was, do you know of any laws that, and it looks like it went to answered already, so I have to go back and grab that. Okay, so was any laws that kind of exclude specific lab results? And actually, I know of two that put conditions, at least two I know of, and I'll just use two examples, conditions on the release of certain test results. So while we have an FAQ about under certain circumstances when we would expect release of test results, and I'll put a plug in now. We have actually a webinar that we'll be doing on June 5th about patient access to test results. But I know the state of California and the state of Kentucky both have preconditions or conditions that must be met before release of certain test results. So I can't say for sure whether or not the CHR company is referencing such, probably more generally referencing the fact that there are laws out there that put some conditions on release of certain test results. So that may be why in that particular instance. But again, I can't speak for that company, but I do know of like California has laws specific to like how results for HIV testing have to be released. And then the state of Kentucky has results about a multitude of different test results regarding conditions that have to be met before the release of those test results. So those are two examples. And then to the second part of the question, I talked about important details of the medication. So just as more of a reminder to another element of information blocking, and that is the definition of EHI. So again, EHI is defined as EPHI that would be in the designated record set, and each covered entity determines what information goes into the designated record set. There are specific information that does have to go into whether it's a plan's designated record set or a provider's designated record set, but then it's supposed to be any information used in the decision making related to the patient. So just want to keep that context that we don't specify what must be in a designated record set, but EHI is defined, and that is the scope of EHI. So please keep that in mind. I think that answers those questions, and my colleagues can always jump in, or I can keep going. But
Mike, I was just
yeah.
going to say you have lots of questions about enforcement and
Sure,
whether
definitely would
it
love
will be
to.
retroactive or going
Okay.
forward.
Yeah, I did see those. So that is not our determination. I can say a couple things on that. If OIG received questions about retroactive enforcement, I assume when you mean by retroactive, you're talking about to the applicability date of the rule of the regulations. So that would be that April 5th, 2021 date. Again, OIG will probably weigh in their final rule, and then that will probably also be addressed separately for the disincentives rule. I will say though, from our perspective, and if you remember that, we can probably even go backwards maybe to the claims flow chart. So there is really no retroactive for us under the program. So those, if there was an information blocking claim that we wanted to take from April 5th regarding developers, there's no retroactivity there because the program was applying at that time, and so was that date. And I'm not sure who's in control of the slides, but I just wanted to go back and just refresh folks on what I'm talking about from ONC authority. So it would have been under way back when Rachel was speaking under the context and background. It was the enforcement piece. And on the OIG final rule, it's been with OMB under review since I believe like April 7th. So again, I've been saying in many presentations that my expectation is we're still not gone back. I'm not sure. Did we miss it? It's under the enforcement section. Okay, hopefully somebody will be able to get to that. Or
No,
give them
you
the
didn't
slide
miss
number.
it. Keep going back.
But my expectation is that rule will publish in the very near future. We're getting there.
One more.
Yes,
Oh.
one more. There it is. So you can see ONC scope. So it says ONC may investigate and may take action under the ONC Health IT program. But remember, ONC action under that program is corrective action. So it's a corrective action process. It's not a punitive process. We don't have authorities under the program to issue civil monetary penalties or disincentives, and obviously not disincentives because we have no authority over healthcare providers. We only have the authority that we have under the under the Health IT certification program, which includes a condition of certification that essentially says the developer is going to attest that they're not going to be an information blocker. So that's how that authority arises for ONC under the program. But if you recall the whole rulemaking, the Cures Act, when we talked about how we would coordinate and work with OIG in any type of investigation enforcement of the information blocking, which they are still waiting to issue or in the process of issuing their final rule. Okay, I think that covers enforcement at least. So we can definitely say we answered those ones. So there's a question about, I'll jump on real quick about registries. And really what I want to say here is, so public health surveillance systems are not a specific actor under the rule. we really have two sets of specific actors. Those are developers of certified health IT, which includes offerer, but offerer, obviously, it's going to depend if you meet the definition, and we've obviously created some or proposed some exclusions in this rulemaking, whether or not you're going to meet that definition of a developer certified health IT. But if you get a product certified under the program, you're definitely going to meet the definition, right? And then you have obviously the healthcare provider definition that's set out in statute and specifies various entities that would be a healthcare provider under that definition. The last one is a health information network, health information exchange, and that is fact-specific, context-based. You have to meet all the conditions, or excuse me, all the provisions of the definition. I'm not sure if we'll be able to get that definition up, but generally speaking, you've got to be supporting exchange between two, I think it's two or more, right? Unaffiliated actors. And so, or excuse me, entities. So, is it possible for immunization registry? Yes, to meet the definition. Will all immunization registries meet the definition? I don't know, because I'm not sure how all the immunization registries in every state function. But is it feasible? Yes, that they can meet the definition if they're meeting, excuse me, could they be an actor in the program if they met the definition of health information network? And I was going to put it up on the screen. Yeah,
okay.
I mean, yeah, well, I was going to try to go to the reg text, the CFR, maybe we could put, but I guess, yeah, you could just read it since we're
Okay.
don't have
So
share.
health information network or health information exchange means an individual or entity that determines, controls, or has the discretion to administer any requirement, policy, or agreement that permits, enables, or requires the use of any technology or services for access, exchange, or use of electronic health information, one, among more than two unaffiliated individuals or entities other than the individual or entity to which this definition might apply, that are enabled to exchange with each other, and two, that is for a treatment, payment, or healthcare operations purpose, as such terms are defined in 164-501, regardless of whether such individuals or entities are subject to the requirements of 45 CFR parts 160 and 164. Would have been more helpful on the screen.
Probably for people to look at. But, the point is, if you're, essentially as an entity taking in what would be HI and you are facilitating one actor's ability, or excuse me, one entity's ability to like pull data from that and then a different entity to get that data out, then, you may meet the definition of health information network. Do we have any other questions that, I know there was a question about examples about, and we're still looking at that, examples of what would be practice or unreasonable. We have been issuing interference examples where we do have a future rulemaking coming as well. So all that is on the table as to what we can do to provide more guidance and certainty to the market as to.
I directed that questioner to our FAQs and to the Cures Act final rule preamble for any examples we could give.
There were some examples there. I do believe we even gave a provider series, right, Rachel, webinar where we kind of ran through some examples, heavily caveated, but some examples as well. Okay, this question was not answered. If an HA by contract prohibited, so it actually was kind of answered. So a couple things I want to say about that one. So we'll answer live. So first is most likely in that situation, the HIE, assuming you're saying it meets the definition, that's an actor. By contract, I'm going to assume that you mean, so the health system, health provider, yes. So that's likely an actor under the information blocking reg. So you have two actors, and I'm guessing when you say by contract, you're talking a business associate agreement. And I think Cassie went over the fact that business associate agreements can be looked at to determine whether or not the provisions in them are interferences. And we have an FAQ that talks about permitted disclosures. So I think you want to consider that piece of it. And then I think but maybe what I was asking is this the only way I have to do it if I do it that way? No, because I remember there was that question. But okay, let me look at this one again. If HA is by contract prohibited from releasing information by health who has contributed, can the HA refer the request to the House? So so I am answering the right part of that. There's no obvious answer, clean answer to that, because we said we would look at the business associate agreement and try potentially to why that determination was made. I will mention that 4006 of the Cures Act encouraged the use of HIEs to make patient information available, to make the release of or patient access to their information, to try to make that a way to get their access. But the bottom line on that particular question, it's not a yes, no to it. It would be why was, we would look at the business, potentially look at the business associate agreement in that instance. And that's what Cassie was talking about. And I think we have the FAQ on that. It talks about permitted disclosures. And in the rule, we talked more about, one of the reasons why that's the case. Why would we do that? Because we received comments on the rule that arguing for a business associate agreement to be an exception by itself. And we flatly rejected that proposition. And we explained, how different entities that contract in that case can have different bargaining power. And sometimes it could be the developer that actually has the bargaining power and that dictates the terms of that business associate agreement, not the covered entity, even though it's the covered entity who obviously has the responsibility there and determines, in terms of who is going to and executing a business associate agreement. So, I mean, without saying, not much more to say there other than it will depend on the circumstance. There isn't a yes, no to that. So we would want to, and I would
Like
point you to the FAQ. Did we put that FAQ in the
I put
chat?
it in the chat. Yeah.
Awesome.
There's
Thank you,
also a
Kat.
great question that just came up in the chat now. Can you just briefly explain how the NPRM process works? For example, NPRM is proposed, comment period, review period, et cetera. How do they become finalized?
Yeah, I really appreciate all of us are probably geeking out on that question. Like that's not where to start, right? So there's always a proposed rule, but before a proposed rule, you can have what are called, and you'll hear these terms like Cassie talked about them. Sometimes you can do them by themselves. They're called either advance notice of proposed rulemaking or RFIs, requests for information. And those can go out prior to any rulemaking, or they can be included in a proposed rule. And really what they're for is to get the public comments and sentiments on particular proposals and to better inform what we propose in a rule. Just to give an example, when we just did one on electronic prior authorization last year, to use that information to help eventually tailor our proposals related to e-prior auth in a proposed rule. So we put out a proposed rule. The comment period, so there are additional like federal, I'll call them federal rules in terms of, but really they're like executive orders, guidance from the Office of Management and Budget about how long a comment period should be. It's always encouraged to be 60 days, but it can be less and they can be extended. So then you would issue notice to extend the comment period. And that's the opportunity in which the public to read the proposals and provide comments on those proposals. I won't get into all, we're almost at time getting into the whole process before it gets out, but obviously the Office of Management Budget helps inform the government's view, the whole government's view of a agency's or department's rule before it goes out. But then it goes out and you have this comment period. And what we try to do during the comment period is give as much presentation, speak about the rule, try to do the best to reach all potential interested parties, constituents to the rule. So like I mentioned earlier, we're going to have a presentation for patients and caregivers so they can understand the rule and what may be most important to them. As well, we'll speak to providers. We obviously speak to developers. We have all these webinars. So we try to get out as much information. We issue fact sheets, so forth, right, about the rule. So that's to help inform you. And then you give us comments. And then we go into what's called the deliberative process privilege stage, kind of, and it occurs anytime before we issue something publicly, in which we are deliberating and considering all the comments we received on the rule, what the implications would be, and then we work with our general counsel as well. And obviously, it's going to go back to OMB before it goes out as a final rule. But the whole process is based on those comments, should we keep the proposal as proposed, or do we have, did we give enough notice? And it's all about notice to the public about what may or could change in that proposal in a final rule. And there's like these legal concepts called like logical outgrowth. So could that have been foreseen how we may change the proposal? So why I was telling you, when you may comment on other things, we may get those comments in and not be able to use them to do anything with a final proposal, but we could use them for future proposals. But anyhow, get all those comments in, and then ultimately we issue what's called a final rule. And there's a lot of things you can do with a final rule. You have to at least have a 30-day delayed effective date unless you go through a process of waiving that, which you may need to do in certain instances. They did a lot of that during the COVID-19 pandemic, public health emergency, to get rule changes on telehealth and out really quickly and effective. But normally you have like a 30-day delayed effective date. Sometimes it can be longer. And then you can also set different compliance timelines. So we did that with the information blocking rule. We set it originally at November in 2020, but then extended it to April of 2021. So those are just some of the features of rulemaking. Hopefully that is helpful to you just in a broad sense of how it works. There's always a proposal, always an opportunity for public comment. Want to consider those comments, and then you're going to finalize the policy based on those comments and considerations in a final rule. And then eventually it'll become effective, in which the parties that are regulated by that agency that would have to comply. Really, thank you for coming today. I know we're a minute past again. This is recorded. We will be back to talk more about the rule before the comment period ends. June 20th, 11:59 p.m. is when the last opportunity to get comments in on the rule. Again, thank you so much for joining us today. I hope you have a great rest of your afternoon. Cassie or Rachel, any last remarks?
Nope, thank you very much.
Just one kind of friendly note, because I'm physically looking at that page of the Federal Register. It does say 5 p.m. instead of 11:59.
Okay. But that's a little inside baseball from us. You usually have to 11:59 p.m. that day. But don't be saying Mike told you that if it isn't accepted, and regulations have changed it. The federal, I think, as Rachel's pointing out in our actual post, the Federal Register rule posting in the text, it says 5 p.m. But,
Thanks,
all right,
everyone.
everyone. Bye now.